The priority in titration is always to open up the airway, meaning to say you always get the EPAP set first, because the EPAP is exactly your CPAP. When you increase the EPAP or you increase the CPAP, that is the most important part of the titration to allow the patient to have an open airway. After that, then you can increase the pressure support or the IPAP. Okay, pediatric practice guidelines, you can read both online, and this is going to be the mode of intervention is also based on the diagnosis of the patients. So again, going back to the most basic of titrations to the most advanced. And now you talk about it in the mode of intervention based on the pathology that you're trying to treat. CPAP is good for OSA patients. Bilevel spontaneous mode is also good with OSA patients and non-compliant CPAP patients. Okay, if the CPAP patients cannot use or have difficulty using the CPAP, they can be switched to bilevel, and that can go all the way up to auto bilevel mode. So the patients with OSA can have CPAP, APAP or automatic auto-adjusting PAP, then bilevel spontaneous mode, or auto bilevel. So it's auto-adjusting IPAP and EPAP. That's for your OSA patients. Now, when it comes to patients that require bilevel titrations that cannot be on CPAP, these are your patients with hypoventilation or lower airway obstruction. One, you have your COPD patients, they can benefit on bilevel. If they're at the beginning of their disease, then they won't need a backup rate. They could be okay with bilevel alone. Some of your neuromuscular disease patients that are diagnosed early on can be on bilevel without a backup rate. So the backup rate can be added later on once the patients start to exhibit central apneas. Okay, that's when you will need a backup rate. ST mode are your COPD patients that are a little bit worse. They have already progressed with the disease state, and your neuromuscular disease patients, also your obesity hyperventilation patients. These patients can all benefit from bilevel without or with a backup rate. Then you have your congestive heart failure patients and your complex sleep apnea patients. Now, these patients might also be exhibiting Cheyne-Stokes respiration. So the only mode that will help them is the ASV. Unless your patients have additional comorbidities, if they have congestive heart failure, but they also suffer from obesity hyperventilation, or they also suffer from any type of, let's say, a neuromuscular disease, right? In addition to their central apneas, then they will require the VAPS, volume assured pressure support. Okay, any patients that have some form of hypoventilation cannot be and should not be on ASV.